Hello everyone. Now I'll be discussing question on cardiology. So we have a 30-year-old lady and she has progressive weakness and shortness of breath over the last several weeks. She has a complaint of significant migraine in the past history and she smoked a pack of cigarette a day since age 17 and now it is 30 years. That means for the last 13 years she is smoking and uses methamphetamine also. Okay. At moment the BP is 88 by 60, pulse tachycardia, saturation is reduced, respiratory rate is 22. Well, and there are sitting upright, diffuse crackle throughout the lung fields, dullness of percussion in the right lung base. Apical impulse is palpated along the left anterior axillary line. You can see it has shifted crossly on the left side. This is an extra short pitch, low pitch sound in early diastole, best heard with the bell of the stethoscope. Legs are cool, pulse are diminished, edema is there. The lab reports show the BUN and creatinine are on the higher side. Okay. Well, patient is giving intravenous medication that act by primarily stimulating beta 1 receptors. Remember, her BP is very low. What is the most likely mechanism by which this medication may improve her condition? Answer is decrease in left ventricular end diastolic volume. It's a beautiful question. Needs a lot of basic concept to be known. So let's discuss why this answer. Well, the answer of this question is decrease in left ventricular end diastolic volume. Long-term use of methamphetamine. She's using this drug for last 13 odd years, and this is associated with cardiomyopathy. And this can occur due to both ischemic mechanism as well as non-ischemic mechanism. But before I proceed further, I have stopped the video, write down the answer. I have a question for you. This methamphetamine is used for what? What is this drug? Okay. Well, first of all, it is a potent CNS stimulant. So that's why it's primarily used as a recreational drug. Right? Well, less commonly it is used for attention deficit hyperactivity disorder as well as to treat obesity. But they are very, very uncommon use. Primarily, it is used as a stimulant drug. Now, this patient presentation, what is given in the question detail, this is considered presentation is quite showing that she has a decompensated heart failure. How can we say? She has progressive dyspnea. Okay. And progressive weakness and shortness of breath over the last several weeks. Cardiomyopathy never develop overnight. That's a several weeks history is there, progressive increase. Hypoxia is there, the pulse oximeter is 91% on saturation, on room temperature and room temperature and room air. Diffuse pulmonary crackles are there. Third heart sound is there. Low pitch early diastolic sound is the classical description of third heart sound, which is a very, very important finding in cardiomyopathy, especially dilated cardiomyopathy. Apical impulse is palpated along the anterior axillary line. Normally it is there in mid clavicular line. Well, this is the clavicle line and axillary line is this, so grossly shifted. And that's again a very important finding that we see in cases of dilated cardiomyopathy. So by and large, the picture is fitting into dilated cardiomyopathy. Well, if you now low cardiac output state are also shown by what? The patient is having cardiogenic shock. BP is 88/60, cool extremities, diminished pulse, and evidence of poor organ perfusion. Now look, in this patient, creatine and creatine is raised, even urea is slightly on the higher side, BUN 40 and creatine 1.9 milligram. They're all due to reduce perfusion, or you can say other term that we can use is a type of pre-renal failure. Okay. Now we are giving dobutamine in this patient. It's a adrenergic agonist drug. Its main activity is act on the beta 1 receptors. But it has got a very minimal activity on beta 2 and alpha 1 receptors. Well, so it is used in management of severe heart failure associated with severe left ventricular systolic dysfunction. Like in this patient, third sound crackles all over the chest and the finding of dyspnea or exertion, all the features they indicate systolic dysfunction. And cardiogenic shock, especially in this patient, already BP is 88/60. So systolic BP below 90 is shock due to whatever reason it may be. Of course, in this case, it's all due to cardiac reason. So we are justified in saying this patient as a case of cardiogenic shock. So we are going to use this drug. Well, now again, I have a simple question for you. Stop the video, write down the answer. Stimulation of beta 1 receptor results in increased production of which messenger? Well, the answer is cyclic AMP. It is released in cardiac myocyte. And what is this cyclic AMP going to do? It in turn enhances calcium mediated binding of actin myosin complex to troponin C. And this leads to increased cardiac myocardial contractility. So you can say it has a positive ionotropic effect. That's what we want. Patient is already in heart failure. We want that something they should have increased pumping action of the myocardium so that more and more lungs are decongested. Well, not only is the increased cardiac contractility, that is ionotropic, even heart rate is also increased via calcium channel activation. So they have a positive chronotropic effect also. So it increases the heart rate and increases the cardiac contractility. Well, now increased myocardial contractility is there, and that due to forward ejection of a larger volume of the blood, and thereby the left ventricle and diastolic volume will be reduced. That's a basic mechanism. Well, cardiac output is increased to perfuse organ and less blood backs up into pulmonary circulation because now the forward flow is better. Forward flow will lead to more and more perfusion, back pressure will be reduced, lung will get decongested. And this results in improvement of symptoms. Well, if you look into other option, decrease heart rate, no, I already told you it leads to increased heart rate. Decrease in myocardial oxygen demand, this is done by the beta blockers. This is not the action of dobutamine. Now, dobutamine, they decrease the heart rate. They are negative. Chronotropic effect. They decrease the cardiac contractility, so they are negative. Ionotropic also. So they have a reverse action of what dobutamine is. Now, because of these two action, oxygen demand is reduced. But at what cost? At the expense of cardiac output get reduced further. So it can even worsen the decompensation. So that's why beta blocker has to be used not to be used or used very cautiously. Okay, there are certain indication of beta blocker, but used in CHF, but by and large, in a usual cases of heart failure, beta blocker are not used. But again, making a statement second time, there are certain indication where we have to use beta blocker, but definitely not in this case. Well, as far as option D, increase in cardiac afterload, it acts via beta-2 receptor, causes small decrease in systemic vascular resistance. I told you the primary action is on the beta-1 receptor, which are there in the myocardium. Beta-2 receptor are there on the arteriole, and they cause small decrease in vascular resistance. Thereby, it will lead to a decrease afterload. Afterload is a measurement of peripheral resistance. Peripheral resistance is 1 by R4. R is the radius of the arteriole. We know very well, arteriole are the main site of peripheral resistance. So when the arteriole get dilated, peripheral resistance goes down. So in this case, they reduce the afterload, not increase. So an increase in systemic vascular resistance will lead to any condition which we cause increased systemic vascular resistance will lead to decreased ejection fraction, increased left ventricle end systolic volume, and worsening heart failure. But fortunately, dobutamine has a reverse action. So it does not increase cardiac output afterload, it decreases afterload. Okay. Well, it increase in cardiac preload. If you see, whatever blood is coming to the right atrium, this is preload. Okay, that's why in patient of congestive heart failure, we restrict water and salt intake. We want less and less water and salt, because if the patient keep on taking extra salt and water, that means more and more blood will come back to the right atrium, and that preload will increase, and that will further worsen the heart failure. Okay, now as far as dobutamine is concerned, it increases heart rate, so it shortens the diastolic filling time, and this leads to decrease in left ventricular end diastolic volume. Okay, so it reduces the preload, not the increases. So it reduces the cardiac preload because reduce diastolic filling time. Now, like diuretics, like furosemide, they are the one, they reduce intravascular volume, and they are the one which really decrease the preload. In fact, to reduce the preload, the best drug is diuretic, but dobutamine has mild effect on the reduction of preload also. But definitely it doesn't increase cardiac preload, that is very definitely. So this is not the answer. So golden line to remember, dobutamine is a potent beta-1 receptor agonist, potent ionotropic effect due to beta-1 receptor, potent ionotropic effect, and there's strong affinity for beta-1 receptor and weak affinity for beta-2 and alpha-1 receptors. It stimulates increased myocardial contractility. And this lead to improve ejection fraction, reduce left ventricular and diastolic volume, and it definitely has a symptomatic improvement of decompensated heart failure. Thank you very much.